So welcome again to our Wednesday morning grand rounds. We have a very special visiting professor, and for our introduction today, I'll turn it over to Dr. Miklau.
Thanks, Drew. So we indeed do have a very special guest today, and wanted to thank Dr. Vallier for taking the time out of her very busy schedule to be with us. She is one of the absolute leaders in orthopedic trauma. She's recognized internationally for her work. Talked about some of it this morning in case review, and we'll be hearing more about it later on today with timing of surgical care or orthopedic interventions. And she's been an advocate or certainly an investigative proponent of early appropriate care, which we'll be listening to today. This is a really busy year for Heather. I've known her for almost 20 years now, and she's a delight to be around, but she's an absolute powerhouse. She's the president of the Orthopaedic Trauma Association this year, first woman president that that organization has had. She has contributed in many ways to the OTA through the board of directors as secretary and the inaugural chair of the publications committee. Heather, if you want to make any plugs for the portal, feel free to do so. She's the deputy editor for the Journal of Orthopedic Trauma and has done a lot of work on her own. She's published over 150 papers. She has, as I mentioned, been involved in many research projects as it relates to the topic that she'll be speaking to us today. Heather is in Cleveland, Ohio. She knows the Bay Area and West Coast well. She's no stranger to that. After Northwestern, where she received her BA, she went to Stanford University for her School of Medicine, the University of Wisconsin for her fellowship, and then Harborview for her residency. And she is a professor of orthopedic surgery at Case Western University and has the inaugural C.L. Nash professorship in orthopedic education. And as you saw from this morning's session, she is a tremendous educator. And in fact, as recently as last year, was voted by the residents to be Educator of the Year at her institution. So I would like to take this opportunity then to have everybody give Heather a warm round of virtual applause. Happy to have her with us. Heather, we're going to have to definitely take a rain check on your being out here. So we'll have to get you out here again when travel is possible. But once again, thank you for taking the time, and we look forward to hearing about your topic of early appropriate care.
Thank you so much for that kind introduction. It's truly an honor to be with you guys today, to exchange ideas and to be with friends, colleagues, and to have the chance to talk about a topic that's a favorite of mine. So thank you for indulging me in that realm as well. This is a lot of work done by a lot of people. I'm going to try to list as many of their names as I can on the very last slide, because it really embodies, I think, not only a big chunk of my professional career and research that I've been interested in, but the work that we've done as an institution, and I think to a greater extent as orthopedic trauma providers, as we continue to learn and to continue to improve upon what we are doing. And so I have some disclosures and add a little bit of the research that I'll show later in this presentation was actually funded by the Orthopaedic Trauma Association. We also have some ongoing grant funding for these entities that are shown here, as well as my current professional ties to the OTA. So what I'd like to do is take a little walk through orthopedic history and reflect back on different perspectives on the timing of fixation, define damage control orthopedics, and then look at some of the supporting evidence for developing plans for fixing patients with multiple injury. And we still have a lot of gaps in our knowledge and in our experiences, but we have a lot of experiences. So we want to kind of take a critical look at as to where we are today and to determine based on that how to develop recommendations for treatment and for implementing them more at a system level while identifying opportunities for further study. So I'm going to throw out a case. I know these cases can be tricky when we're virtual because it's hard to call on people, but just think on this for a second. Here's a patient that came into our place now from a few years ago, but a 22-year-old who was in a motor vehicle collision, was ejected, was intubated at the scene because he was a little bit lethargic and was noted to have weak motor function in both of his legs. He had this closed femoral shaft fracture. CT scan slices from his spine and from his chest are shown here, but basically had some facial injuries, a subdural hematoma, bilateral pulmonary contusions with bilateral pneumothoraces, multiple rib fractures, a small splenic laceration, and multiple levels of spinal injury. The T6-7 flexion distraction injury, L1 first, and then this diaphyseal fracture of the femur that I mentioned. So upon arrival, he's a little bit tachycardic, maintaining a systolic blood pressure of 100, mildly acidotic with a lactate of 4.3 and a pH of 7.31. He received 4 liters of normal saline, 2 units of packed blood cells, bilateral chest tubes were placed, and he was put into distal femoral skeletal traction. 8 hours later, it's now early in the morning the following day, he remains mildly tachycardic, but maintaining a systolic blood pressure of 100. His lactate has improved, his pH is normalized. The question is what's the most appropriate course of orthopedic care? For you, PD5 is on the call. Maybe the OR charge nurse is calling you and saying you have a trauma room. Do you have a case? Do you want to start? So my question to you is, do you have a case? Is this a patient you want to take to the OR now, later? What are you going to do? What sequence are you going to do it in? What table are you going to ask for? I want you to kind of mull that over for a little while. And we're going to come back to this at the end, maybe exchange some ideas on that, because there's a lot of different ways you could do it, certainly. So getting to a little more background, I think we could argue that early stabilization of femur fractures is a standard of care, and that damage control orthopedics is an alternative to definitive fixation for some patients based on systemic profile, maybe soft tissue or other concerns. But for the most part, early stabilization with an IML is what we're going to do. I would argue that thinking beyond the femur, this patient who falls from a height and has this mechanically unstable pelvic ring injury may also have some hemodynamic instability associated with it, is sort of in a similar situation. Both of these patients are going to be in skeletal traction and in bed, and often recumbent, until they can be reduced and stabilized. So that's a difficult thing for that patient until they can get up and they're alleviated of some of that pulmonary burden of being in bed. Furthermore, I'm going to take it another step and say that some of these mechanically unstable thoracolumbar fractures, now this is a pretty extreme example, it's fracture dislocation, but the same thing, this patient is going to be in bed, it's going to be recumbent until this fracture is reduced and stabilized. So these fractures impart pain, they impart recumbency, that's a big hit to their pulmonary system, let alone any pulmonary injury they may have accrued in this injury event. And that's problematic because that's going to set up that patient to have a whole cascade of symptoms and problems if they are not reduced and stabilized in an expeditious fashion, whatever that means. So based on that, early definitive fixation may be considered the standard of care in stable patients. I've emphasized those two words, early and stable, because that means different things to different people. What is early? Is early the first 24 hours? Is 24 hours after arrival, 24 hours after injury? Why do we pick 24 hours? It's just an arbitrary one day. It's because what we've done. What is stable? Are they hemodynamically stable? Are we looking at acidosis? Are we looking at other things? What do we base that on? And so that's where I think we really need to continue to hone our efforts. We recognize these benefits of fixation, but we argue about when and how and what are we looking at in order to determine the readiness for the OR. Historically, as you know, back in the 60s and 70s, we didn't have the instrumentation, the radiography, the technical capabilities, or even the experience to do things that we do now. So we've made tons of progress in a lot of arenas. Most of these patients were left in bed in traction with no fixation or with very delayed fixation with cursory implants and instrumentation. In the 70s and 80s, early fixation was advocated in large part by some of our true orthopedic pioneers, a handful of which I've listed here, but fixation provides pain relief. It promotes upright positioning, so eliminates the recumbency and thus improves ventilation and oxygenation, and improves mobility, and ultimately improves muscular function and the speed with which people recover. So it's a good thing for all those reasons. And if you go back to, classic orthopedic study, Larry Bone et al. From JBGS in 1989, and for the residents on the meeting, if you've never looked at this study, this is a must read as a resident. It's really neat to go back and take this piece of orthopedic history and some of the time around it and use it as a building block for your understanding as to what we do today based on the past. But this was a randomized trial of patients to early, which they defined as within 24 hours of injury, versus late, that is greater than 48 hours after injury, femoral fixation with an IM nail. Half the patients had multiple system injury and half of them were isolated femurs. And we couldn't do this study today because we know that deliberately delaying these patients from fixation of their femur would be not a good thing. It would be unethical. And it's kind of what they found. They found that the delay particularly in multiple trauma patients was bad. It was associated with more ARDS, more pneumonia, more fat embolism, longer hospital stays, and longer costs. They had more mortality in that group. It's a pivotal study. It really showed how profoundly fixation of the femur contributed to the well-being of that patient. Now, it led to additional questions, of course, which most research does, but it's an important piece of what we do. What ended up happening around that time is this concept of early total care, where not only do people recognize, hey, it's good to fix femurs, we should fix other things too. And so it led to longer OR settings where in polytrauma patients, like the case that we just looked at, stabilization of all the fractures and stabilization definitively, not necessarily provisionally, was undertaken. And we know that that can be dangerous now in under-resuscitated patients, can lead to a cascade of organ failure and a variety of other systemic problems. There's also soft tissue concerns, which I'm not even going to get into in terms of wound healing, wound dehiscence, all that kind of thing. So if you think about it as a pendulum swinging from one end on the left, tractions and splints, over to this idea of early total care on the right, it swung by a lot of different options in the middle, which I think is where we are a little bit more today as our understanding has grown. One of the people to call many of these practices into question was Christophe Papé, and he and other colleagues questioned this quite a bit in the 90s from a variety of different angles. And this is just one of many papers that I think is worth thinking about. And they looked at 106 patients who had a femoral nail done, and some of them were multiply injured and some were not. And so in looking at patients with a chest injury or without a chest injury, the severe chest trauma patients had the highest rates of ARDS and mortality when early nailing was done. And they considered early nailing patients who had a femoral nail within the first 24 hours. However, they also found that in patients with no chest trauma or minor chest trauma, the early nailing was beneficial. It got them up quicker, it reduced complications, got them out of the hospital. So it's kind of in a snapshot what we saw with Larry Bone. But it also asked, well, is the nailing contributing to chest injury? Or, it's a chicken and egg problem, really, at this point. But they called into question, are we getting more ARDS because we're nailing? And then specifically because we're doing reamed nailing as opposed to unreamed nailing. And there's a whole another area of study into one versus the other and just the technique of the IM nailing itself. This led the pendulum to swing back the other way toward what we know now as damage control orthopedics. And the term damage control is actually a military term. It goes back to the USS Midway, which was commissioned in 1945, largest ship in her class, kind of neat. And if you poke around on the internet, you might find this picture that I got of this guy who's part of the damage control department on the ship. And their job was to look at these over 1,700 compartments on the ship and be able to compartmentalize any damage from another missile, from fire, to prevent the ship from sinking. So damage control, stop our ship from sinking. As it applies to orthopedics, the guys at Shock Trauma coined this term back in 2000 when they published this paper looking at primary external fixation in patients with femoral shaft fracture as an alternative to IM nailing in patients who were critically ill. And this is just a large case series where they used external fixation as a bridge, as a precursor to IM nailing in patients with multiple injuries. And they felt that some of the contraindications to early nailing were severe head injury, hemodynamic instability, severe chest trauma. And they noted that the external fixation provided rigid fixation, so it was a little bit better than just skeletal traction. It provided better control of the bone. That's a little less ongoing soft tissue trauma, a little bit less pain for the patient, better nursing care, and at the expense of very little operating room time and very little bleeding. So it had some of the benefits of stabilizing the femur without doing it definitively. And we understand this to be a regular thing today. I think most people are pretty familiar with the concept. We take someone from being stuck in traction to being able to have external fixture on. So it's provisional fixation, providing stability with little surgical damage, and then avoiding what's called a second hit. Erica was getting into this when she was presenting this morning, and this idea of a first hit and a second hit. And if we look at this diagrammatically, if you think about time on the x-axis and the amount of systemic inflammation that that person is experiencing here on the y-axis, this injury is a curve on the graph of inflammation and burden and bleeding to that person. If we do a lot of surgery, we may create a lot more bleeding, a lot more inflammation, a lot more response. And theoretically, maybe there's even sort of a line, if you will, as posed by this yellow line on the graph here, after which at threshold level, patients will begin to experience some level of demise, like renal failure, DIC, ARDS, so multiple organ failure, and even death. This is obviously oversimplified, but I think you get the idea that the surgery is going to create additional trauma, even though we're treating the injury and we know there's benefits to the surgery. Maybe sometimes the surgery is too much. And so delayed definitive care, as is projected by this curve down here, is not necessarily good either, because then we still have problems with more pneumonias and more thrombotic issues. But if we do damage control, we just make a little blip on the curve. It's probably okay. Not a lot of extra OR time. Now, most of the time, it's not that clear cut, but I think schematically, it's important to think about what are we trying to do, and then to think about what are some of the issues around damage control. So in a nutshell, trauma deaths, a lot of them are immediate. They're at the scene. They're massive hemorrhage, bad head injuries, things that people never even make to the hospital. Then there's this little blip in the middle of the ones that we've done pretty well with, I think, as trauma systems in terms of severe head injury and mitigating that, in terms of patients who come in with severe bleeding, and we have means to control that, massive pelvic fractures, intra-aortic balloon pumps, Reboa, that type of thing that we're doing now, where we have some control. This curve over here on the far right, I think we improved a lot upon, say 20 to 30 years ago. We started figuring that out a little bit and have done better. But it's these secondary and tertiary deaths due to organ failure and ARDS. And that's what damage control has helped us to do better with. And I think it's a work in progress. But to really reduce those deaths that occur weeks later from these other issues. So as we already mentioned, previous damage control orthopedic literature has focused mostly on femur fractures. It's easy because femurs are common. We see a lot of them. Yet I want you to think beyond the femur to these mechanically unstable injuries of the pelvis, the acetabulum, the thoracolumbar spine, because they affect the patient similarly. Even though they can be technically more difficult to deal with, I think we have to think of them as to their effect on the patient. So pull it all together and go back to our pendulum. We've now swung back. We have this idea of damage control. It helps, but when do we use it? And this is a graph that you saw earlier this morning if you were listening to the cases, and it comes from Capet again. And if you look at it carefully, don't get overwhelmed. There's 4 categories at the top that were posed. And this is based on clinical experience. It's not based on research data, at least at this point, but stable, borderline, unstable, and in extremis patients were the 4 categories that they described. And they based this on patients' blood pressure, their coagulation, temperature, and then associated injuries. And at the bottom in yellow, you'll see that last row recommends a strategy ranging from early total care all the way to damage control orthopedics on the other side. And it's this borderline group that's problematic because many of our patients are going to kind of fall into that group, at least initially. And so, I think that this chart presents a lot of information that's very important to consider when determining your initial treatment strategy. It's tricky because, as Erica mentioned, they can be in lots of different categories. They don't always come out that cleanly. Furthermore, if you look down here, just an associated injury of a mechanically unstable pelvic fracture or severe chest trauma may bump someone into this extremis category, yet maybe after getting a couple liters of fluid, they're actually looking pretty good. You're ED. So how do you reconcile that, and what do you do next? I think it's a good set of issues to think about, but it can't guide our treatment as effectively as it was originally proposed to. So it's another piece of the pathway of history. This algorithm was in fact applied to a group of patients in a multi-center study that was published in 2007. This is looking specifically at patients with femoral shaft fractures and randomizing the people in that borderline group to either having external fixation or intramedullary nail fixation of their femoral shaft fracture to say, hey, is it okay to treat these people with a femoral nail, or should we just be doing an external fixer? And what they found was that there were no differences in pneumonia, in inflammatory response syndrome, multiple organ failure, or sepsis when they were compared. That's that fourth bullet point from the top, which I've underlined. But at the bottom here, you see ALI was significantly less common after external fixation than with an IM nail. And that was one of their significant research findings. And I have to admit, when I read this paper, ALI, I'm looking at that, what does that mean? ALI, acute lung injury. And what it is it's a subtle measurement of oxygenation. So it's an altered PaO2, FiO2 ratio that happens. And so what it probably indicates is that these patients that were treated with IML were oxygenating a little bit less effectively. And that was significantly different than those that had XFX. Now, it didn't play out into more complications like pneumonia or other things, but there are differences. So it's probably safe, but there is a little bit of a pulmonary hit when those borderline patients are treated with a nail. Now, if we go back to shock trauma, they coined the term and look at their experience over a larger case series. They looked at over 200 femur fractures, and only 12% of those patients had an external fixture placed initially. This was not a randomized study. It wasn't even a study that was designed to look at external fixation until they went back retrospectively. But what they found is that they reserved the damage control strategy for patients who had an elevated lactate, were hemodynamically unstable, or had a very severe head injury. Yet, as Erica mentioned, they had pretty good outcomes in both groups. And so they felt that most patients could be safely treated with primary intramedullary nailing, which they defined as within 24 hours. Again, we're stuck on that 24 thing, as long as they were resuscitated adequately. The part I want to quibble with is, what does that mean, resuscitated adequately? We still haven't quite figured that out. We have ideas about it. There's been a number of really bright people with tons of experience who are proposing ideas, but we haven't really been able to study it effectively in a larger group of patients. I'd also argue that there are these problems that you likely see in your own practices, and look at like this guy on the left here. He gets in a motorcycle crash, comes in, and he has this complex femoral fracture. It's actually a neck with a perotrochanteric component, segmental shaft, and it's open. So that's just, I can't just put an X fix on that. I could put some skeletal traction on that, but it's not going to be real stable until we can definitively stabilize it. That's challenging. It's not a really super straightforward case either. What about this other film here? This lady has a pre-existing implant, then has a shaft fracture. So whether you just try to use medullary fixation or plate fixation, either way, you're looking at a relatively longer case. Implant removal, replace the nail, versus some kind of plating, and then a lot of soft tissue dissection. Not straightforward. And so there's a total chip shot femur in a thin patient with a simple pattern where it's not too swollen, and then there's this. And I think they're two very different animals. And so we really need some way of assessing patients that's going to allow us to determine the safety of doing these larger procedures, even if it's a femur. Furthermore, some of these injuries, like pelvic mass tabular injuries, may not even be amenable to external fixation. And what about, an acetabulum? And you say, well, this is going to take me 3, 4, even 5 hours to reduce it and stabilize it, and a lot of surgical bleeding. When is that okay? Do I use different criteria? And so I think that these are some of the challenges that we're slowly chipping away at in terms of our understanding of how to provide optimal care to a multiple injured patient. And regarding damage control orthopedics, we had a nice session at the OT meeting this past fall looking at parameters. There's a lot of immunological parameters that are affected by the injury that have some genetic predisposition, and things that we're still learning about. But some of that's problematic too, because most of these markers aren't readily available at your hospital. If you order them, they may not even come back for 12 hours or 36 hours. And so that doesn't help you in the fray of the situation to make your decisions. And so if we look at what we have, this is what our group tried to do, and take a large set of our experience in dealing with patients with multiple system injury and these fractures of interest. Can we come up with a way, a protocol even, was our goal, to determine how to safely manage these injuries, which would allow us to say, well, for different types of injuries, is there a time that we can recommend? Are there certain patient parameters that we're looking for? Is it something as simple as acidosis, or should we routinely be using all of these other things? Can we make a mathematical formula? That was what we set out to do, and we developed a a multidisciplinary research group, including our colleagues from orthopedic spine, neurosurge spine, and head trauma, to pulmonary critical care, and a couple of our anesthesiologists, to scratch our heads and look at our data together. And this was part of our journey as a system into looking at this. And our purpose was to define which injuries and parameters warrant a delay of definitive care. And knowing that, to determine what timing for fixation is best once patients are resuscitated, but also to propose what do we consider adequate resuscitation in order to do this, and to have a model whereby we could predict complications and reduce complications from our prior historical level for fractures of the femur, so diaphyseal fractures and proximal femoral fractures, pelvis ring, acetabulum, and thoracolumbar spine. So that whole grab bag of fractures that's going to relegate that person to being in bed until they're reduced and stabilized. Not talking about a little LC1 where you can probably walk on it right away. We also decided not to include, elderly people with falls from a low energy event and hip fractures. These are polytraumatized patients. They could be older, they could be younger, but it's a different energy of injury. And so you look here at the breakdown of the patients that we studied. It was over 1,400, and there's a mixture of fractures are listed here. Mean age of 38 and a mean injury severity score of 25. So it's pretty injured from a system standpoint. Our historical tactic was to treat the femurs pretty early, but on some of the other fractures, we were delaying more often. So in terms of the measurements here, early is defined as anything within the first 24 hours following injury, it's shown in yellow, versus red is later. So our institutional perspective was, of course, like most, I think, to focus on that femoral shaft. It's a little easier, it's a little more familiar, and that was what we did. But what were the reasons for delay of fixation of the other injuries? Well, a lot of our patients come from outside hospitals, and so a little over half of them were transferred, and that accounted for a lot of the delayed patients. So there's some time element that it purely takes someone time as they go to another place to get here. In the winter particularly, or if there's bad storms, our helicopters can't always fly. People have to come by ground. It does take longer. Surgeon preference was a big one. Many surgeons, and so previously in our hospital, it wasn't like, oh, we have a trauma room every day and there's always a person in the trauma room and someone to take care of these injuries. More just like, oh, it came in on my call on Monday, so on Thursday, we have the afternoon, so let's do it then. Surgeon preference, surgeon availability, even OR availability to some extent. And I consider our trauma system to be relatively mature, but this is just peeling back everything to expose what were we doing at that time. Very little of the delays were actually from patient instability. Occasionally they were, but that was a much less frequent issue, or things that needed further medical workup. So in terms of injury to that group of patients, you can see here that many of them had chest injuries, abdominal injuries, or head injuries, and we broke down all their injury types by using the AIS system in order to have the severity of injury as part of the variables that we looked at. 22% of those patients developed early complications. They were primarily pulmonary and thrombotic complications, as are shown here. And so we weren't following these patients later on. So this does not include, non-unions or malunions or anything. This is all about that initial hospitalization and those first few weeks following injury and what complications they had. We noticed that severe acidosis on presentation was associated with complications. So for example, this again showing time on the x-axis and pH on the y-axis. People who developed pneumonia, as shown with the blue line, had much lower pH when they arrived and took a long time to get back to normal. Look here at 48 hours, many of them are still below a normal pH. So in composite, the complications were related to the initial magnitude of acidosis, and it was the same whether we measured it by pH, base excess, or lactate. You can measure any of those, it all works. And also, those complications were related to the rate of improvement of the acidosis over time. So we had a mathematician working with us on this and looking at modeling. It was really helpful because he also had a PhD in statistics, and he could look at things and help us to develop equations to see what the probability of pneumonia or other complication events would be based on our sample if someone presented at a certain acidosis level, and then what would happen to them over the first 24, 48 hours, et cetera, based on how they were resuscitated. So in terms of our goal of developing a predictive model to determine when would complications develop, we found that 3 elements were really critical. The first was the initial acidosis, and again, it could be measured by pH, base excess, or lactate. Then, how did that acidosis improve over time? We also found that lactate, as you guys are probably aware, was most specific, and this makes sense. That's been shown by other people. It's also the easiest because we can get it from a venous sample. We don't need an arterial sample to check it, so it's simpler and faster to get at it. The second item that was important for developing a predictive model was the severity of the chest injury. So presence of a chest injury and how severe was it was very important. And that's consistent, as you've seen with prior literature, going back to the stuff that we looked at from the 90s earlier in this presentation. The third item was the timing of definitive fixation. So we looked at the time to fixation from the time of injury, not the time they got to the hospital. When did they get hurt? When did they get definitively fixed? And so in looking at this, we collected a lot of additional data. We looked at vital signs, like every 4 hours. We looked at a variety of different labs and all of these different injuries and tried to come up with what items do we need to include in order to tell us when is it safe to go to the OR for said fracture. And do we need a different model for each type of fracture or for fractures that are anticipated to have so much EBL or whatever the case might be. We looked at it a lot of different ways to try to discern what would be the safest way to manage patients going forward. And what we tried to do was agree that our complication rate that I showed a couple slides ago was 22%. We wanted to design a protocol that would get our complications down by 10% or down to around 12% total from our 22. So decreasing it by 10 more percentage points. What we found was that acidosis was important, as I stated on the previous slide. And if you look at a cutoff level, if we could find one, because these things have been proposed in other literature, but it was all based on retrospective sample. When we did a modeling thing, what we found is that an incremental analysis of these parameters of acidosis, if the pH had gotten to 7.25 or better, it seemed mathematically like we would be able to achieve that level of decreasing our complications down to 12%. Similarly, our target for base excess became negative 5.5, and our lactate became something less than 4. Now, it's interesting because we were meeting every week as a group. We would meet and we'd talk about this, and our mathematician would come and we'd slowly parse away at the data and banter about what we should do. And I remember the day that we sat down and these parameters came back, and he said, yeah, I think I know. I've incrementally looked at this by tenths and then by 50 hundredths of decimal points of each of these labs. As long as the lactate is less than 4, it seems to be the cutoff. We did not believe this guy. Like, we looked at this and said, wow, that's really high. I don't know if I'm comfortable taking some of the OR for definitive surgery if their lactate is like 3.8 or 3.6. It just seems so different than what we've been doing. It seems that they're still under resuscitated. And in looking at the data suggested otherwise. It suggested that if we were meeting these parameters based on our historical experience, it should be safe. It should put us at a safe level that would actually be a better level of reduced complications than we were at beforehand. So stay with me here. Another really cool thing that he developed was this thing where we have a little probability measure. As a sidebar for you guys who are very IT savvy, I'm not. I think it would be fun to have this where you could have something in your phone where you could just plug it in and it would tell you the probability, whatever. But here's some examples of the program that we had. Was what if a person has no chest injury? So second point here, no chest injury, lactate is less than 4, and fixation within the first 24 hours. Their probability of pneumonia was 3.6%. Conversely, drop it down to the bottom, a person with severe chest injury. So maybe it's an AIS of 4. They've got a flail chest with a hemothorax. Their lactate is less than 4, but you're going to delay their fixation of their pelvis for more than 48 hours. Well, their risk of pneumonia is actually pretty high. So we can do this now based on that data set. The limitations of which, of course, this is our hospital. This is our system. It's our surgeons. Is it applicable to another facility? Maybe, maybe not, because there are differences. We all have subtle differences in how we care for that patient. It's also a snapshot in time. You could argue that our ventilator management is better now than it was when we did this. Our nutrition is better now than when we did this. And so maybe the numbers are different. They probably are. But given those limitations, this is something better. And so we decided to try it. And taking these principles in hand, I'm going to move into the last segment of my talk and talk a little bit about our prospective work in using parameters that we developed from this initial data. And I guess just to summarize briefly before we do that, we can agree that unstable spine and pelvis and anti-acetabular fractures have a similar effect on patients as those femur fractures do. We can also agree that early skeletal stability is important, whether it's provisional via some type of damage control strategy or perhaps skeletal traction, or definitive. It does impart benefit to that patient physiologically. But fixation while controlling bleeding is also going to cause some bleeding and also put patients at some risk of pulmonary compromise just because they're under anesthesia and relegated to that position in the OR, perhaps prone, lateral, other positions that we put them in, which can be problematic too, depending on their baseline status and their injury to their chest. Further, we agree that acidosis is predictive of complications and that we should proceed with early definitive fixation once someone is adequately resuscitated. Now we have some better ideas on what we're calling adequate resuscitation in order to proceed. We can also say that the severe chest injury is going to be associated with complications, and it actually is worse if we wait longer. And so if someone has a severe chest injury, we should not delay our fixation for that. We should acknowledge if they have a severe chest injury, we're going to be watching closely. They're going to have trouble potentially, but we still need to reduce and stabilize their fractures expeditiously once they're resuscitated to an appropriate level. And so in terms of our pendulum, we developed this term called early appropriate care in an effort to be distinguishing from early total care. We don't mean try to fix everything every time. I mean early appropriate care in that maybe that early care is something provisional. Maybe it's external fixation. Maybe it's some combination of definitive fixation and external fixation, depending on that patient scenario. But to proceed with expeditious fracture fixation for these major skeletal injuries, which may be definitive, provisional, or some combination thereof, as long as that person is adequately resuscitated as based on our parameters. One thing before I progress is I want to mention about the time. I've been kind of ripping on this idea of within 24 hours being, yeah, that's just what we used. Well, we looked at time kind of as a continuous variable, and we looked at it all the way through 96 hours. And what was interesting about that, and I think that, you know, you guys have done some work on timing too, and you've looked at National Trauma Data Bank, and so I think you can relate. We discovered in our own sample that after about 40 hours following injury was when patients really started to decline. If they had not been definitively stabilized and they were in that window once past about 40 hours, they started to really deteriorate from a pulmonary standpoint. And so while our group felt, well, you know, a lot of people like to work off of that 24-hour thing, we don't really need to do that. We agreed as a system and as a multidisciplinary team to decide to try for 36 hours. And that our target was for patients who were resuscitated according to our parameters, we would proceed with definitive fixation within the first 36 hours following injury, because it kept us under 40 by a little bit. But 36 is easier. Think about it. In the last couple of weeks, you know, you get that person that comes in with a complex acetabular fracture dislocation, and they arrive at like, you know, 4 in the morning, and they're still not really resuscitated, ready to go. And then they're ready to go at like, you know, 4 in the afternoon. That's not looking so great. Nobody likes starting those cases at like 5 or 6 o'clock at night. But you know, how about you've got them in some skeletal traction, they're really ready, you take care of some other patients in the meanwhile, and you do that person as first start the following day. It actually worked out much better from a system standpoint in terms of surgeon well-being and surgeon longevity too, which is something we all should be thinking about in terms of sustaining ourselves and sustaining our system. Okay. So back to the protocol. We propose to provide definitive fixation to femur, pelvis, acetabulum, and thoracolumbar spine injuries within 36 hours if these laboratory parameters were met and if the patient was continuing to respond to resuscitation. So again, this is not just one point in time. We actually have order sets, and so these are checked at a minimum of every 6 hours until they normalize, and that's just kind of how our system has worked since we started doing this protocol. We hypothesized that EAC patients treated within the protocol recommendations would have fewer complications than our historical cohort, and that those treated within 36 hours would have fewer complications versus patients who were delayed longer than that. So prospectively, we did this as a system, and this is the first 2.5 years after we started doing this. So in order for the patients to be included in this, they had to have a minimum ISS of greater than 16 and have their orthopedic injury being a fracture of interest and injury to at least one other major body system. And so their mean age was 39 with a mean injury severity score of 27, and their other injuries are listed here. Interestingly, all of these patients actually met the resuscitation criteria within 36 hours. People ask, well, what if, they're still asthmatic? And I think, when you think about it, the ones that didn't exsanguinated very shortly after arrival, or they died shortly after because of a massive head injury or some other reason, but the resuscitation really wasn't what was holding them up. So that's an important point to take away. Of that group, 80% were definitively treated within 36 hours. So you go, wow, 80, not so good. Well, as a system, look at what we were doing before. We were frustrated because we wanted to try to get everybody on board, but this gets into behavior and how do systems work. And so while there was a lot of change in terms of management, particularly of acetabular fractures and mechanically unstable spine fractures being fixed much earlier, there was still a little bit of room for improvement. But at the same time, that gave us more data for us to learn about what we were doing and to identify areas that we could improve upon in terms of how we work as a team and in terms of how we take care of individual patients. We also had 3 protocol violations where surgery was performed in under-resuscitated patients. People got excited and said, well, we're just going to nail the femur because we're here anyway. It's like, yeah, we shouldn't really be doing that. That's not appropriate. But it happened. It happened 3 times. We found that in terms of implementing this, if you look at consecutive quarters or 3-month periods of implementation here on the x-axis, the amount of patients that had delayed fixation really decreased. And right now we're at probably about 93 to 95% adherence to this protocol within our system. There's still a few here and there, surgeon choice reasons. Sometimes there's issues around patients wanting to wait. They're waiting for a family member to arrive from out of town, just various things that still come up that delay us from better adherence to the protocol. But this is how our system has been working so far. So if you look at the 20% that had delayed surgery that were resuscitated according to parameters and could have gone to the OR, these are the reasons. Kind of makes sense. And it's still mostly surgeon choice. What we found is that we looked at those early complications, like I showed before. There were fewer in the group that was treated according to protocol in yellow within 36 hours. You see the red bars denote those patients that were delayed, who had more pulmonary and more total complications. Another question that I get asked a lot is, well, what about, they have an open ankle fracture dislocation. Do you fix that while you're there? Do you wait? Well, we looked at this too, and we found that when patients had multiple procedures performed in the same setting, as opposed to coming back to the operating room for another setting, they actually had fewer complications and they had shorter lengths of hospital stay. And it kind of makes sense. And so this gets back to the point that we made, I think, during the first case we looked at this morning earlier. And that is, I think it's okay to continue, but you need to keep reassessing that patient and make sure, are they still responding okay to the work you're doing? Are they ventilating okay? Are they oxygenating okay? And if so, then go ahead and continue. Are those soft tissues of the area you want to work on amenable to continue? Maybe they are, maybe they aren't. And so you have points of off ramp, but it is okay to do more than, just nailing the femur in the same setting. And in most cases, it's actually beneficial to the patient. What about the chest injury? Well, as we've already noted, chest injury is really common. Severe chest injury is pretty common, and it does increase complications. But what was interesting about this prospective EAC cohort is that there was an equal percentage of the severe chest injuries in both the early and the delayed groups. And the pulmonary complications were over twice as high in the patients that had no chest injury. And so in reality, the patients who were delayed actually had more problems with chest complications than did the other ones. And that makes sense too. It's kind of what we wanted to see. I think this element becomes even more problematic in our spine patients. And most systems, I think, struggle with these spine cases because sometimes there's territorial issues over who's managing it. Is it orthopedics? Is it neurosurgery? Many times the people who have the expertise to do the spine cases, the longer cases, there's not as many surgeons potentially available who can do them. And it's often traditionally not what they've done to stabilize these spine fractures on a more acute basis. Compound that with the severe chest trauma is pretty common in the patients that have thoracolumbar spine injuries that are unstable. So it's problematic. If we look at in our EAC series here, the second bullet point, the spine fracture patients had more complications as a whole, and I think a lot of it relates to the severity of their underlying chest injuries. But here's a key point. The time to definitive fixation was a mean of 26 hours from injury in the patients who had no complications versus 68 hours in the patients who had complications. And you could say, well, that's just because the sicker patients were more delayed, and it actually wasn't. This is after controlling for those variables. And so it really has to do with how long those patients are down, and they do tend to have more problems, particularly pneumonias and chest complications, when they're not stabilized early. So if we look at our historical group here on the column on the right versus the early EAC patients, there was a significant reduction in complications with the protocol, and a decrease, which was not significant and underpowered in terms of pulmonary complications at this first pass. If we translate this into length of stay, certainly the yellow bars is indicating shorter hospital stays, shorter ICU stays, and shorter mechanical ventilation times when the EAC protocol was followed. Financially, this is a big deal. I mean, we look at the cost, and these are costs, not charges, for each delayed patient purely based on longer length of stay was not inconsequential. Our facility collections also decreased, and that has to do with the way that we get paid in terms of various DRGs. The bottom line, and now this data is already several years old, so the dollar values have gone up in accordance with inflation, but shorter length of stay and fewer complications from adherence to the EAC protocol helped save our hospital almost $2 million a year. And so that we thought that was pretty good. I feel more compelled by the clinical reasons, but this is a nice way to try to justify it when you're talking to your operating room leadership. So in summary, definitive fixation should occur when patients are adequately resuscitated. The EAC protocol relies on team-based care, simple parameters, continuous reassessment, and universal application to all trauma patients. According to the prospective data, all the patients were resuscitated within 36 hours. Only 80% were definitively treated in that time, and non-medical issues accounted for most of the surgical delays. Complications were over twice as common, and length of stay was over twice as long with delayed definitive surgery. And we saved the hospital nearly $2 million a year. So to go back to our case, we've got this guy, he was ejected. He has some neurological deficit associated with this multifocal spine injury. He was intubated, and we don't have a super accurate motor and sensory examination on him now, but he's got a closed femoral shaft fracture, a severe chest injury, and this spinal injury. 8 hours later, it's 6 in the morning. The OR charge nurse calls, you have a trauma room. His vital signs are stable, mild tachycardia. His acidosis has improved. What do you want to do? Erica, what do you want to do? You did such a nice case presentation earlier. I know you're all over this topic. You're still on the meeting.
Heather, I think Erica had to jump off to do a trauma fellowship interview. So let's pitch it over to maybe Zach or Adam, one of our trauma fellows. They'll be making these decisions pretty soon.
Sounds good. Throw something out there. There's no perfectly right or wrong answer. I think it's an interesting one to discuss. I hope it is.
Sure. So I would consider taking this patient to the OR for intramedullary nailing of the femur. At this point, I think things are trending in the right direction.
Yeah. So that makes a lot of sense. We recognize the value in relatively straightforward femur. I'm not trying to hide anything here. There's no associated proximal or distal fractures associated with that. But yeah, you do an IM nail of the femur. What do you think about his spine? His spine needs to be reduced and stabilized. How would you approach that? Who are you going to talk to, and what do you think they would say?
Absolutely, I think we would interface with both the general surgeon, trauma team, as well as whoever at the institution is on call for the spine portion. Certainly, we would keep this patient supine. We would maintain precautions regardless of if and when we did our portion of the fixation. So I would do this on a flat Jackson. But like you said, the thoracolumbar unstable injuries take just as much precedence, if not more, than this femur. So I think I would discuss with them.
Yeah, I think that's really important. And every system's going to have a slightly different tactic, and it depends a little bit on availability of your spine surgeons. We're fortunate that we have 3 very adept spine trauma surgeons here, and they take a week at a time, and they have a spine trauma room every day. So that's not usual. I think that's one far end of the spectrum. That many institutions may not even have an orthopedic trauma room, or they have it under certain conditions, even though that's a whole nother political and organizational issue. So fixing the femur is important. We understand that. And then fixing the spine. And so our goal is, well, if he's doing okay now, maybe we can accomplish both of those things, potentially in the same anesthetic setting. And our spine surgeon proposed, well, I'd like to fix the spine first. And you know how this is. Everybody always wants to go first. We all want to go first. They all want to go first. How do we do it? And in reality, kind of thought about it and said, well, yeah, I think that's okay. We could either put an X fix on the femur, or this patient really looks pretty good. He's 22. I don't think there's any active ongoing bleeding going on. You could fix the spine. We see how he's doing, get him back into a supine position. That would be how I would do the femur. So you could do femur lateral too if you wanted to. But then nail his femur if he's doing okay. And otherwise, we put an external fixer on and we leave the OR, and maybe we come back the next day. And so that was the plan that we had going in. And so that morning, he went and had percutaneous pedicle screws. So his spine was reduced and fixed. His labs actually continued to improve in the operating room. He remained okay in terms of his ventilation and his oxygenation. And so he got this anti-grade nail afterward and was actually extubated the following day. Now, of course, this is the case I'm showing. He didn't have any bad complications. They don't all work out perfectly. I completely disclose and acknowledge that. But I wanted to show this example because it's a combination of injuries that are challenging for institutional reasons and for practice pattern reasons, and to start to think. And I feel like this is where we need to go with a lot of this, whether it's maybe he has a complex acetabular fracture in the hospital. Well, there's only one guy who does the acetabulums, and he's here on Tuesdays and Fridays, so we're going to have to wait for that. And I feel like these are things that we need to start to break down as we go forward, so we can optimize the care of each individual to expedite their fracture reductions and fixation and still provide high quality individual fracture care, but to do it every day. And we need to do it every weekend. And those are hard things. I'm not saying that each of us should be available every day of the week to do all these things. I don't think that that's feasible or healthy for that matter in terms of individual well-being. But in terms of patient care and institutional well-being and what we should strive for, I think we as a system need to gradually get there. And there's a lot of ways we could talk about in terms of within a given geographical area to ensure that there's surgeons available within a certain radius who are available said days of the week to cover cases like this. And I hope that that's where our future lies as we continue to go forward. I just have to acknowledge all the people who provided a lot of energy and help with EAC at our hospital, from the research team to the education committee, protocol development team, and our steering committee, and our wonderful colleagues who have helped us with this now for quite a long time. And I thank you for your attention and the ability to talk this morning.
That was great. Thank you so much. And thanks again for joining us. And I think really interesting, impressive work that should really help a lot of people. And I think we do have time and could open it up for questions. If anybody wants to unmute themselves or virtually raise your hand, and can make sure we get everybody answered.
Heather, I have a question.
Yeah.
If I can get started, I really thank you for all of this impressive body of work. It's really advanced our field dramatically and been really helpful in breaking down some old paradigms around strict timing definitions, and I think really elegantly identified a few parameters that that even orthopedic surgeons can kind of grasp. And I wonder with that if this is really is this the end of the story in terms of understanding when a patient is adequately resuscitated? I mean, we're in an era of big data and machine learning and all this stuff that the residents are teaching me about. And I wonder if there's not going to be even more sophistication in terms of identifying the physiologic state of our patients in order to make more informed decisions.
Yeah, I think you are spot on with where you're going with that. And I'm optimistic that through big data and data sharing across institutions, that we can continue to refine these parameters, because this is very simple. And in part, we were happy to make it simple as a starting point. But some of the things we've been looking at are, well, what about patients as they get older? And it's not just chronological age, but physiological age. And what about, their underlying COPD, their underlying heart failure, their underlying chronic kidney disease, all of these things that people can bring to the table, some of which we don't even necessarily know about or know the extent of when they arrive. And so I feel like it's inevitably much more complicated and sort of nuancing an individual. But I feel like as a composite, these parameters are safe. And for us, they resulted in improvement, vast improvement upon what we were doing previously. So I feel like we're just chipping away at this. When we took a chop out of it and we made a little bit of progress. But what I'd like to see happen is more sharing across institutions to learn how to nuance these parameters in timing. And I think things like more tailored resuscitation, particularly with respect to coagulopathy, I think is going to be really important in the next several years, and continuing to incorporate that into the mix. But maybe having something where we prospectively collect a lot of data as we go, and we incrementally analyze it quarterly, annually, and look back as to what are we doing, and recognize some of the patients in high risk groups, because those parameters may be a little bit too aggressive for some patients. I think the issue about the timing itself, whether you're going to do some type of a damage control intervention or a definitive intervention, that 40-hour or a little over 40-hour time point is a real thing. And you can see it. I mean, you guys have seen it in the work you did. I think we got to be really cautious about letting people wait. It bothers me when I see things happen here at our hospital, which is infrequent, or if I visit somewhere else and there's some guy with a really unstable spine injury and it's like day 4, day 5, and now they're not doing that well. I don't know when we're going to get in the OR. It's really something that we need as a trauma system and as a country, and even globally, to put more emphasis on ways that we can work together across institutions to get patients to the facility, to the providers they need to be with, so that this care can be delivered every day in controlled OR. I'm not saying we could go back and do these cases in the middle of the night. I think that is generally not a good thing for well-being and for that individual patient even, but that we have systems that can allow for this type of care to happen every day of the week. Resources are allocated because it is clinically appropriate and it is cost effective.
Thank you.
Heather, I just wanted to thank you again for presenting. I know we're cutting it closer on time, and one of the things that I think, in having followed this debate ever since Chris Pape brought up the reamed unreamed nail discussion, is that a lot of this gets back to inflammation. I think that's one of the big unanswered questions in orthopedics now. Systemic local inflammation, important for trauma, important for tissue regeneration. It seems like, following up Sam's question, there are better ways probably to do this, either through our ability to control inflammation, detect, control it, and also determine if there are any predispositions to people's reactions to an inflammatory causing event. What's on the horizon to try to reconcile what is sort of resuscitation with inflammation and the control of that? I know Todd McKinley's group's working a little bit on that, but it gets to the precision medicine issue a little bit.
Oh, it definitely does. And I think, Todd's looking at it from, individual organ standpoint, and other people also looking at more of a genetic element, even at Vanderbilt and other places where they look at genetic types. I mean, I hope that in the next 5 to 10 years, we're really going to make some headway on this and understanding this. So if someone comes in, we can identify them as, oh, this person has a gene type that's at high risk for inflammation. And so we need a different set of parameters, but we also need to use something that's going to mitigate that inflammatory burden. And so knowing that, we can respond. I think that the piece around how to treat the inflammation and how to prevent the inflammation are sort of two different things. And hopefully our interventions will be assessing that as we go forward. I still feel like we need a little bit more unity across institutions to say, well, let's share data. And this is happening a little bit. You know, part of what Metric did to develop some infrastructure was okay, but some of it may be a little bit cumbersome right now. We need to figure out ways that we can share information and look at specific questions, prospectively agree on certain data that we're going to collect, and then go back and reflect and refine. And I don't think it's I don't think it would be difficult as long as we're organized in how we do it, because these are patients that we're seeing all the time, every week. There's tons of them coming in, and we need institutional standardizations, but that there's a lot of ways that we can improve on this little bit of where we are now. I mean, I bet in the next several years with the inflammation piece that we can really reduce ARDS and organ failure to be almost a thing of the past. I mean, already it's so much better than it was, say, 20 to 30 years ago. So, you know, we still have things to do, but I believe that by uniting with each other, that's how we're gonna really start to get at it. So through both the treatment and mitigation of inflammation and that understood genetic piece. That's kind of the wild card. But in a very basic way, that's the way I see it going, or I sure hope it goes. What do you think?
Thanks. No, I think it's not only connecting us, I think it's connecting us to the general surgeons. They're doing a lot of work on this, and also the basic science groups, because this is evolving. Inflammation, I mean, we've even seen it with COVID, has multi-organ, multi-system consequences. And some people are better able to deal with it than others. And so we also need to integrate cross disciplines.
Yeah. That's awesome.
And maybe we have time for maybe one more question.
I can ask something.
Heather, it's Amir Matitiao. How are you? Mayor, you can go. Yep.
Well,
Go ahead, Mayor. It's okay.
Hi, Heather. Excellent talk. Thank you for that. You alluded to it a little bit in your talk when you said that a femur fracture is not a femur fracture, and there's also a role about what we do in the operating room. And I was just wondering, because doing early appropriate care, and under the term appropriate care, there could be a lot of things could be labeled under that. So how do you, when you are in this situation, in the 36-hour, how do you judge how long you're able to stay in the operating room? Is it just the anesthesiologist telling you he's fine? Are you asking for any particular parameters? Are you judging time in the operating room? What's your approach to that?
I usually look at it a little bit by time and a little bit by their soft tissue envelope, you know, and then I also look at, well, how am I doing? Is this getting to be late in the day? Are we on our, you know, fourth team of people? Everybody, you know, once you get past 3 o'clock, oh, there's 2 nurses coming in, and there's another set, and everybody's kind of checking out, you know. And so how is the team doing? How is the patient doing? And what's safe to continue? And honestly, sometimes I get in a situation where we'll fix a few different things. If we've got an early start on it and we're moving along and the patient is okay, we'll continue. We may get it done or mostly done, with the caveat that articular injuries, we're planning something more extensile, and for soft tissue reasons, I would treat with an X-Fix. I would usually delay those for maybe 10, 14, 20 days, depending on the injury. But most of the time we will continue. I think sometimes if it's, you know, late into the day, or especially late into a weekend, and we're starting, I'll say, you know what, let's bring him back again tomorrow, as long as he's doing okay, and then we'll fix his acetabulum, or whatever the case might be, and just trying to coordinate that. I feel like that's partly me, because as I get older, I realize that I get more tired. I don't want to cut corners. I don't want to be operating at a level where I'm not doing my best work, because now we're into the evening. So sometimes I'll make decisions based on that. It's really individualized. And I think that should be your call, and your call in conjunction with that patient and your team members, both the people working with you in the OR and the leaders from the other disciplines, as to what is the best plan of action. So it's a little hard to generalize, but I hope that helps you a little bit.
Great. And just in light of time, I think we should probably plan to wrap up, but I feel like we could continue the discussion. And thanks again so much. It's really excellent work, and really appreciate you sharing that with us, and joining us. And I think, like Dr. Miklau said earlier, hopefully we can get you out to the Bay Area at some point in the future when that's a possibility.
That would be a lot of fun. You guys have been such generous hosts, and I really love your energy and your wonderful questions and participation. Thank you so much for this opportunity.
Thank you for
Have a
joining
nice day.
Thank you.
Thanks, Heather. Bye-bye.